Dear class, this is the second part of pituitary and thyroid hormone. In contrast to the hormones of the anterior lobe of the pituitary, those of the posterior lobe, vasopressin and oxytocin, are not regulated by releasing hormones. Instead, they are synthesized in the hypothalamus, transported to posterior pituitary, and released in response to specific physiologic signals such as high plasma osmolarity or parturition. Each is a nanopeptide with a circular structure due to a disulfide bridge. Reduction of disulfide inactivates these hormones. Oxytocin, originally extracted from animal posterior pituitaries, is now chemically synthesized. Its only use is in obstetrics, where it is employed to stimulate uterine contraction to induce or reinforce labor. To induce labor, the drug is administered intravenously. Oxytocin causes milk ejection by contracting the myoepithelial cells around the mammary alveoli. Vasopressin, also known as antidiuretic hormone, has both antidiuretic and vasopressor effect or vasoconstrictor effect. In the kidney, it binds to the V2 receptor to increase water permeability and reabsorption in the collecting tubules. Other effects of vasopressin are mediated by the V1 receptor, which is found in the liver, vascular smooth muscle, where it causes constriction, and other tissues. To avoid its pressor properties, vasopressin has been modified to desmopressin, which has minimal activity at the V1 receptor, making it largely free of pressor effects. This analog is now preferred for diabetes insipidus and nocturnal enuresis and is longer acting than vasopressin. The thyroid gland facilitates normal growth and maturation by maintaining a level of metabolism in the tissue that is optimal for their normal function. The two major thyroid hormones are triiodothyronine T3, the most active form, and thyroxine T4. Although the thyroid gland is not essential for life, inadequate secretion of thyroid hormone, hypothyroidism, result in bradycardia, poor resistance to cold, and mental and physical slowing. In children, this can cause mental retardation and dwarfism. If, however, an excess of thyroid hormone is secreted, hypothyroidism, then tachycardia and cardiac arrhythmia, body wasting, nervousness, trauma, and excess heat production can occur. Thyroid gland is made up of multiple follicles that consist of single layer of epithelial cells surrounding a lumen filled with thyroglobulin, which is the storage form of thyroid hormone. Thyroid function is controlled by trophic hormone, thyroid stimulating hormone. Thyroid stimulating hormone is a glycoprotein structurally related to luteinizing hormone and follicle stimulating hormone, which is synthesized by anterior pituitary. Thyroid stimulating hormone generation is governed by the hypothalamic thyrotropin releasing hormone. TSH action is mediated by cyclic AMP and lead to stimulation of iodide uptake. Oxidation to iodine I2 by a peroxidase is followed by iodination of thyroxine on thyroglobulin. Condensation of 2-diiodotyrosine residue gives rise to T4, whereas condensation of monoiodotyrosine residue with a diiodotyrosine residue generates T3, which is still bound to the protein. The hormones are released following proteolytic cleavage of thyroglobulin. Secretion of TSH by anterior pituitary is stimulated by hypothalamic TRH thyroid thyroid releasing hormone. Feedback inhibition of TRH occur with high level of circulating thyroid hormone. At pharmacologic dose, dopamine, somatostatin, or glucocorticoid can suppress TSH secretion. Both T4 and T3 must dissociate from the thyroxine binding plasma protein prior to entry into the cell, either by diffusion or by active transport. In the cell, T4 is enzymatically deiodinated to T3, which enter the nucleus and attach to a specific receptor. The activation of this receptor promotes the formation of RNA and subsequent protein synthesis, which is responsible for the effects of T4. T4 is converted to T3 by one of two distinct deiodinases depending on the tissue. Hypothyroidism usually results from autoimmune destruction of the gland or the peroxidase and is diagnosed by elevated TSH. Antibodies to thyroid peroxidase are diagnostic for Hashimoto thyroiditis. It is treated with levothyroxine T4. The drug is given once daily because of its long half-life. Steady state is achieved in 6 to 8 weeks. Toxicity is directly related to the T4 levels and manifests itself as nervousness, heart palpitation, and tachycardia, intolerance to heat, and unexplained weight loss. Excess amount of thyroid hormone in the circulation are associated with a number of disease states, including Graves' disease, toxic adenoma, and goiter. In this situation, TSH levels are reduced due to negative feedback. The goal of therapy is to decrease synthesis and/or release of additional hormone. This can be accomplished by removing part or all of the thyroid gland, by inhibiting synthesis of the hormone, or by blocking release of the hormone from the follicle. The thioamides, propylthiouracil, and methimazole are concentrated in the thyroid, where they inhibit both the oxidative processes required for iodination of thyroxyl group and the condensation coupling of iodotyrosine to form T3 and T4. PTU can also block the conversion of T4 to T3. Note, these drugs have no effect on the thyroglobulin already stored in the gland, therefore observation of any clinical effect of these drugs may be delayed until thyroglobulin stores are depleted. Several doses of PTU are required per day. Methimazole is administered in 3 equally divided doses at approximately 8-hour intervals. Because of the potential for liver toxicity or liver failure, PTU should be reserved for patients who are intolerant of methimazole. Removal of part or all of the thyroid. This can be accomplished either surgically or by destruction of the gland by beta particle emitted by radioactive iodine, which is selectively taken up by the thyroid follicle cells. Younger patients are treated with the isotope without prior pretreatment with methimazole, whereas the opposite is the case in elderly patients. Most patients become hypothyroid as a result of this drug and require treatment with levothyroxine. Thyroid storm present with extreme symptoms of hypothyroidism. The therapeutic options for thyroid storm are the same as those for hypothyroidism, except that the drugs are given in higher doses and more frequently. Beta blockers that lack sympathomimetic activity such as propranolol are effective in blunting widespread sympathetic stimulation that occur in hyperthyroidism. Intravenous administration is effective in treating thyroid storm.